So I'm going to speak on best ventilator strategies for patients on ECMO with ARDS. The strategies for mechanical ventilation fundamentally revolve around the prevention or minimization of ventilated associated lung injury. In year 2000, the ARDS rate demonstrated that 6 ml per kg was better than 12 ml per kg in improving the outcomes in ARDS. While in 2015, Marcelo Ameto told us that it was not the tidal volume per kg body weight, but the tidal volume which was normalized to available lung compliance that matters. So they told us that the tidal volume available to lung complex, which is calculated as blood pressure minus PEEP, and also called as driving pressure, when it was kept below 15 centimeters of water, improved outcome. Essentially, what it means was if you titrate your PEEP in such a way that you keep your driving pressure below 15 centimeters of water and blood pressure below 28 centimeters of water, you see there is a significant reduction in mortality. But driving pressure is still not validated in pediatric age group. And some studies have shown that if you keep it less than 12 centimeters of water in normal lung, and in PIRDS or pediatric ERDS, if it is kept below 14 centimeters of water, it improves the outcome. Although PILIC 2 has recommended to keep driving pressure below 15 centimeters of water, taking from the adult studies. In 2016, Gattironi et al. Gave us this equation for mechanical power, which has got three essential components of elastic component, resistive component, and static component. And when they are multiplied by respiratory rate, we get the equation of mechanical power. As per the available literature, there is no consensus on what should be the safe ventilator strategy on VV ECMO. The also recommended range is keeping the blood pressure below 25. There is no recommendation on tidal volume. The positive end expiratory pressure should be kept between 10 to 24 as per them. FiO2 as low as possible and respiratory rate of 4 to 15. While EOLIA protocol is to keep the blood pressure less than 24, tidal volume to be adjusted in such a way that blood pressure is kept below 24 or at 24. Positive end expiratory pressure should be 10 or above. FiO2 for around 0.3 to 0.5 and respiratory rate of 4 to 30. Caesar trial gave the protocol of respiratory rate of 10, FiO2 of 0.3 to 0.5, PEEP of 10, no recommendation of tidal volume, and blood pressure to be kept below 20 centimeters of water. There are two important studies which I would like to discuss before we dwell more into the ventilator strategies. This was the paper published in 2019 from American Journal of Respiratory Critical Care Medicine on pig model of ARDS treated with VV ECMO. They were ventilated with non-protective ventilator strategy of high tidal volume 10 ml per kg and respiratory rate of 20 breaths per minute. Protective strategy of tidal volume of 6 ml per kg and respiratory rate of 20 breaths per minute. And near apneic setting of tidal volume of just 2.1 ml per kg and respiratory rate of 5 breaths per minute. And they found that near apneic ventilation demonstrated least injury on immunohistochemical staining with less alveolar disruption and neutrophilic infiltration. Histological lung injury and fibroproliferation scores positively correlated with driving pressure and mechanical power, and hence they concluded that decreasing the strain and mechanical energy applied to lungs of ARDS patient by combining ECMO with near apneic ventilator setting may actually help prevent fibroproliferative phenotype. The second study is again in 2019 from critical care medicine, and here the patients were kept on ECMO and on APRV bilevel ventilatory strategy of 1 second of 24 centimeters of water and 2 seconds of 12 centimeters of water, and they were randomized into three categories: the very high PEEP and very low driving pressure category, the low positive end expiratory pressure and high driving pressure category, and low positive end expiratory pressure and low driving pressure category. And the plasma soluble receptors for advanced glycation end product, that is SRAGE, which are a marker of alveolar epithelial and type 2 pneumocyte injury, and the inflammatory markers like plasma IL-6 levels were significantly reduced by, at least by 60 to 70% between protective and the ultra-protective ventilator strategies. So these two studies are clearly supporting near apneic and ultra-protective ventilator strategies. Similarly, back in 2013, during H1N1 pandemic, it was found that higher blood pressures on first day under ECMO was significantly associated with increased ICU mortality. This was an interesting trial which was done in 2013, where they had in one group ARDS-NET strategy protocol followed at 6 ml per kg without any extracorporeal device. And in another arm, they had very low tidal volume ventilation with 3 ml per kg. And because of that, when carbon dioxide was accumulating, it was removed by extracorporeally by ECOR, or extracorporeal carbon dioxide elimination method. And they found there was a significant improvement in 28 days ventilator free days and 60 days ventilator free days. A similar study in 2014 was performed in animals with the two conditions. In one condition, ARDS net protocol was followed as before. And in another, instead of low tidal volume, they use low respiratory rate. And whatever resulting high carbon dioxide was removed extracorporeally. And they also found that there was significant improvement in the all types of inflammatory cytokines when low respiratory rate was used. So these two trials also support low tidal volume and low respiratory rate ventilatory strategies. This was the study in 2015 by Schmidt et al. From France, and it demonstrated that high PEEP levels during the first 3 days of ECMO were independently associated with lower ICU mortality. So we have seen plateau pressure, tidal volume, respiratory rate, and positive index PEEP. Now the question is, how should we select the PEEP? Whether it should be based on the oxygenation-based indices like PEEP FiO2 table or pulmonary mechanics-based indices. That means setting the PEEP by achieving best compliance with least plateau pressure and least driving pressure. So looking at PALIC 2 recommendation now, they are recommending using the low PEEP high FiO2 table, which is basically based upon Robinder Khaimani's study, which had shown that whenever the PEEP was set below these levels, their mortality was higher. So, but when you look at practically speaking, 60% FiO2 with PEEP of 10 and 70% FiO2 PEEP of 14, this looks little on the higher side, because normally in pediatric ICUs, we don't use such high levels of PEEP. And when I looked at some important publications from pediatric age group, this was in respiratory care from India, and these two studies from Europe, we can see, and they're all recent publications, we can see the median PEEP in all the studies with children on ARDS actually was around 6 to 7 centimeters of water. So not very high PEEP. So we are not used to using very high positive intestinal pressure in our units. Personally, in our unit, we don't use PEEP FiO2 table. We use PEEP titration based upon best oxidation, best compliance, least driving pressure, least plateau pressure, and best carbon dioxide clearance. This meta-analysis also showed that there was not any significant benefit of using high PEEP versus low PEEP strategy in improving mortality or any complications. Although they showed that higher PEEP levels were improving the oxygenation, but oxygenation improvement was not necessarily going to increase the overall outcome, improve the overall outcome. These two papers are good, interesting reads, I would say, which were published in Critical Care in 2022. One talking about supporting the theory of PEEP FiO2 table and oxygenation-based PEEP titration, and another as a rebuttal, which is supporting the pulmonary mechanics-based PEEP titration. So is it so simple? Just look at, keep the lowest possible FiO2, lowest tidal volume respiratory rate, and you get better outcomes. So let us see. This was an interesting publication from 2022. In the experimental arm, they used everything which you can imagine as ventilatory or lung protection or lung protective strategy. They used tidal volume of just 1 to 2 ml per kg with respiratory rate of only 5 to 10 per minute. And the PEEP was titrated using transpulmonary pressure monitoring. And all of them were proned for at least 16 hours during the 48-hour study period, while the other control arm was ventilated as per the EULIA trial, which we discussed in the previous slides. And to big surprise, they found that there was not much difference in the two arms in terms of outcome or anything. And this is interesting. Similarly, earlier study in 2019 by Schmidt et al., which was the largest international multicentric prospective cohort study in 350 patients, found no association between ventilator settings during the first 2 days of ECMO and survival in the multivariable analysis. The author found that although there was a significant fall in mechanical power as soon as you start ECMO compared to pre-ECMO setting, but there was not much difference between the mechanical power of survivors and non-survivors subsequently. after starting ECMO. Similarly, driving pressure also reduced after starting ECMO compared to pre-ECMO levels. But then between survivors and non-survivors, there was not much difference. They cited two important reasons for this. One, they thought that maybe one reason maybe the centers which they recruited for their study were already very skilled centers. They were very experienced centers in implementation of ultra-protective ventilator strategies, and all anything resulting from ultra-protective ventilator strategies like hypoxia or hypercarbia, the teams were skilled enough to manage by increasing the flows on ECMO and sweep gas flows, etc. So they were very skilled, and that's why they did not change the outcome. And second reason they cited was the driving pressure use was very low. And the idea of using low driving pressure was mainly to target low tidal volume. The intention of using driving pressure was never to achieve any acceptable gas exchange. Hence, this driving pressure which they used during ECMO was actually unlikely to be of any prognostic value. Now, coming to pediatric literature, it is important to know what pediatric literature says, because pediatric lungs behave differently compared to adults. Infant lungs may be less susceptible to ventilator-induced lung injury when exposed to comparable ventilator settings of tidal volume or pressure, as the studies have shown that in the end of inspiration, the alveolar size are more uniform in infants as compared to adult lungs, and the utility of positive end expiratory pressure or recruitment maneuvers may differ in infants compared to adults. And hence, we need to be a little careful when we extrapolate the literature from adult age group. Moreover, it is not clear whether low tidal volume ventilation is actually beneficial in children as compared to adults. This one is an interesting read, a good review article by Dr. Martin Neighbor and his team, comparing the similarities and differences between children and adult in ventilator-induced lung injury. It was published in American Journal of Respiratory Critical Care Medicine in 2014. And here is the list of the papers which they had cited in their study, which did not support the evidence of high tidal volume being associated with mortality. And in the same paper, they also enlisted the studies which support the evidence of high tidal volume with the mortality in pediatric age group. So it is still not sure. We are not sure whether it is beneficial or not. And that is why the PEMVEC guideline as well as the PALIC 2 guidelines are now giving us a range of tidal volume. They're not asking us to ventilate only at 6 ml per kg. They're giving a range of 4 to 8 ml per kg of tidal volume. And if there is a poor lung compliance, even up to 3 ml per kg. Friedman et al. In 2021 had enrolled children between 14 days to 18 years from ELSO registry. And in their study, they found in bivariate analysis, all the ventilator parameters like FiO2, PEEP, positive end expiratory pressure, mean airway pressure were higher in non-survivors compared to survivors. However, when they performed a multivariable logistic regression analysis, then they found FiO2 was the only parameter that was an independent risk factor for mortality, something similar to what Schmidt et al. Found. One more question which we always ask is which mode to be used, pressure control or volume control, or PRVC, which some people may find it shocking. So, well, there are meta-analysis report no difference in mortality rate between various modes, although this particular meta-analysis compared mainly against the high-frequency oscillation. HFOV, APRV, both have not found to improve the outcomes in pediatric age group. In volume control and PRVC mode, we need to choose a tidal volume. And as we already know, PALIC and PAMVEC have given a range of 4 to 8 ml per kg to choose. So it becomes difficult for us to select. But in pressure control mode, we can titrate the PEEP and then we can select our driving pressure. So if it is a severe ARDS, we can decide that I'm not going to go with a driving pressure above 14 or 15. So then we can set our PIP above our titrated PEEP, making sure that driving pressure is not more than 15. And then depending upon the available lung compliance, the lungs will choose their own tidal volume. For example, if we have a set titrated PEEP of 8 centimeters of water in a particular patient, and then we decided that we are not going to exceed the driving pressure of 14 centimeters of water. So we set up PIP of 22 centimeters of water. And if the lung compliance is poor, it will choose its own tidal volume of, say, 4 ml per kg. And as the compliance is improving, then the tidal volume will gradually increase because it's a pressure control mode, and it may go up to 8 ml per kg. So the lung will choose its own tidal volume as the compliance improves. And if we compare it with Amato et al.'s paper of 2015, we can see that the pressure control mode is mostly behaving the way they had also shown, that if you titrate your PEEP in such a way that you keep your drying pressure less than 15 and make sure that blood pressure is less than 28, then you will see reduction in mortality. So theoretically speaking, at least we can say that pressure control behaves more like what Amato had found, and that's why it is better to choose pressure control, and apart from decelerating flow and other advantages. Coming to ancillary strategies, neuromuscular and muscular blocking agents, they are used in severe ARDS in children with ECMO, and accuracy trials supported using early administration of neuromuscular blocking agents in severe ARDS. And Rose trial gave a contradicting result with no significant difference in mortality at 90 days between those who received early and continuous cetracranium infusion and those who were treated with the usual care approach with lighter sedations. But many patients on ECMO are still managed with the muscle relaxants in initial 24-48 hours at least when they are having severe ARDS and high ECMO settings, although there is no concrete evidence to support this practice. Nitric oxide is one important intervention. Although the studies have not showed any associated improvement in outcome with nitric oxide. However, clinicians use it as a rescue therapy or as a bridge to ECMO initiation. It is still not clear whether after initiation of ECMO, whether we should continue using nitric oxide. This important paper in 2020 has shown an interesting thing. They showed that if there is a right ventricular dysfunction on day 1, and if there is a persistent right ventricular dysfunction even on day 3 after diagnosing ARDS, then the outcomes are a little, they are going to be worse for those patients with persistent right ventricular dysfunction. And if in such cases where you have a right ventricular dysfunction, even after initiation of ECMO, theoretically speaking, and nitric oxide may be useful. Prone positioning is an important intervention. This elegant trial, which was the study on animals, which was done by Bhushan Katira in 2021, demonstrated that the pleural pressures and in the transpulmonary pressure are higher in the prone position. Therefore, the transpulmonary pressure, sorry, the pleural pressures are higher in the prone position, and therefore the transpulmonary pressure decreases during the prone position at the end of positive end expiratory pressure. So the pronation basically reduced the pleural pressure gradient and made the lung inflation more homogeneous between the dependent and non-dependent areas. And PEEP maintains lung homogeneity at most levels only during pronation. Although there are conflicting clinical studies, this particular study showed that patients who underwent prone positioning on ECMO had a longer ICU length of stay and ECMO duration, while this monocentric study found that at the end of prone positioning, all patients supported with VV ECMO had a decrease in the electrical impedance tomography estimated optimal PEEP and an improvement in the local compliance, tidal volume, and end expiratory lung impedance redistribution. In fact, the author suggested to prone all the ARDS patients supported with VV ECMO regardless of their predicted response in terms of static compliance improvement. Coming to spontaneous breathing on ECMO, BiPAP, PRV are the modes where they promote spontaneous breathing, and the idea is to prevent respiratory muscle wasting, improve hemodynamics, and decrease sedation needs. Only thing we need to understand and remember is these lungs with ARDS are abnormal lungs or injured lungs, and they are not normal lungs. They don't have that fluid-like behavior of normal lung. And hence, when there is a spontaneous breathing in such injured lungs, there is always a risk of pendulum effect, that is air moving from non-dependent areas to dependent areas without change in the tidal volume, which may result in patient self-inflicted lung injury. Awake ECMO is very useful in patients with very severe end-stage lung disease, who are awaiting lung transplants, or immunocompromised patients to reduce the risk of infections. Also, very severe asthmatics and pneumocystis carinii pneumonia. Careful patient selections and planning are essential for awake ECMO, and highly trained team of doctors and nurses are needed to implement awake ECMO. Hence, very few units in the world practice. This particular paper, review article on awake ECMO, is very useful read, I would suggest, which was published in Indian Journal of Thoracic Cardiovascular Surgery on this particular topic. So to conclude, or before conclusion, I would say this interesting comment by the authors in this paper is an important thing to understand. that if you keep very low settings of tidal volume and respiratory rate, basically you are exposing to hypoxia and hypercarbia, and this will ultimately force you to keep higher ECMO blood flows and sweep gas flows, and which can expose the patient to the problems of hemolysis, and also it can lead to a possible increased duration of stay on ECMO. And also, when your patient is on low tidal volume for a long time, there is always a possibility that when you try to wean down from the ventilator and ECMO, there will be problems of atelectoma on atelectasis and prolonged weaning periods. So you need to be a little careful, and too conservative ventilation strategy also is not right. That we need to understand. So what can we conclude? Pressure control mode probably better than volume control or PRVC, but again depends upon the experience and the overall comfort level of the nurses and doctors in their unit. FiO2 of 0.3 to 0.5, that is lowest possible. Lower respiratory rate of 8 to 12 breaths per minute. Set your plateau pressure to deliver the tidal volume of 3 to 8 ml per kg with driving pressure below 12 to 15. If the lungs are relatively normal, then 12. If the lungs are bad, then 15 driving pressure. Target plateau pressure below 25. ECMO sweep gas should be used liberally to support these lung protective strategies and to address air hunger. Set the positive endoscopic pressure as per the need and situation. We don't use PEEP FiO2 table, but then again, we need a good randomized control trial to compare which type of PEEP titration is better. Plan weaning when tidal volume delivery improves from the same or very safe driving pressure. Decisions regarding nitric oxide with or without high frequency oscillation, prone positioning, bronchoscopy, neuromuscular blocking agents, or allowing with spontaneous breathing with use of APRV, BiPAP, etc., should be based upon the individual clinical scenarios. Thank you very much.